Good morning, everyone. My name is Sandro Galea, and I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school, welcome to this public health conversation. Before we begin, a word of thanks to everybody who helped make today happen. First of all, thank you to our co-host, the Journal of Urban Health, and a thank you to our team led by Meredith Brown and Alicia Noel. Thank you. This public health conversation commemorates the 20th anniversary of an event which changed our world as profoundly perhaps as any event ever has. The terror attacks of September 11th touched all our lives. Everyone who remembers the day likely has a story of where they were when they heard the news or of a loved one lost in the attacks. I was in New York City on 9/11, and my early career was deeply shaped by studying how the trauma of the attacks affected the physical and mental health of those affected. In many ways, I think in thinking about 9/11, it is impossible to disentangle the intimate, the personal, from the broader implications of the day. As we discuss these implications, we do so mindful of the many human stories which underlie them. The study of population health is at core about people, about our shared humanity of which 9/11 was a reminder. Thank you to our speakers and to everybody in attendance for joining us as we discuss the hard-won knowledge that emerged from the day and the days after. I'm now going to turn the day over to today's moderator, Dr. David Vlahov. Dr. Vlahov is editor-in-chief of today's co-host, the Journal of Urban Health. He's Associate Dean of Research and a professor at the Yale School of Nursing. He's also a professor of epidemiology at the Yale School of Public Health. David is a friend, collaborator, and longtime mentor to whom I'm immensely indebted. I very much look forward to learning from David and from all the panelists, as I always do. David, over to you.
Sandro, thank you. It's really an honor to be here and with such a great panel. So let me get started. I'm going to introduce the speakers. First, we're going to hear from Mark Farfel, who is the director of the World Trade Center Registry of the New York City Department of Health and Mental Hygiene. Our second speaker will be Dr. Barbara Rothbaum, and she is the director of the Emory Healthcare Veterans Program. She's professor and associate vice chair of clinical research at the Emory School of Medicine in the Department of Psychiatry and Behavioral Sciences, and director of the Trauma and Anxiety Recovery Program. She holds the Paul Janssen Chair in Neuropsychopharmacology, and she specializes in research in the treatment of anxiety disorders, particularly PTSD. Our third speaker, we're going to turn to Alboliz Santiago Colon, who's Associate Service Fellow in the Research Planning and Care Integration Unit at the World Trade Center Health Program. That is administered by the National Institute of Occupational Safety and Health under the Centers for Disease Control and Prevention. The program provides no-cost medical monitoring and treatment for certified World Trade Center related health conditions to those directly affected by the 9/11 attacks in New York, the Pentagon, and Shanksville, Pennsylvania. Our final speaker is Dr. Rachel Yehuda, who is professor and vice chair of psychiatry and professor of neuroscience at the Icahn School of Medicine at Mount Sinai. She is also the mental health director at the Bronx Veterans Affairs, and she is recognized as a leader in the field of traumatic stress studies and has authored hundreds of papers and 10 books in the field of traumatic stress and neuroscience of PTSD. So I'm going to turn now to Dr. Farfel, and please.
Thank you, David, and thank you for this opportunity. I will begin with some brief background on the World Trade Center Health Registry, which is based in the New York City Department of Health. And two key reasons that we have a registry is that health department leadership recognized the need soon after 9/11, and the federal government has provided continuous funding and support for us. The registry has diverse groups of responders and civilian survivors, including people who lived, worked, or went to school in Lower Manhattan, passers-by, and rescue recovery workers. In 2003, 2004, we began tracking the health of more than 71,000 people who voluntarily enrolled and took the initial health survey. and they comprise nearly 1 in 5 of the estimated 400,000 people who were eligible. Since then, we've conducted 4 follow-up health surveys with input from community, labor, and scientific advisors and the World Trade Center Health Program. And the most recent ended earlier this year. And we tracked the physical and mental health outcomes, gaps in care, quality of life, functional status, and other consequences such as early retirement. While the registry was not designed to provide clinical care, we do collaborate with the health program to respond to enrollee health needs and concerns as a core part of what we do at the registry. So far, the registry has over 150 publications reporting on a range of health outcomes of 9/11. I'll briefly mention some key findings and lessons learned today. First, 9/11 has had enduring and significant impacts on survivors' physical and mental health, health behaviors, quality of life, and functioning. The most common 9/11 related health conditions are post-traumatic stress disorder, PTSD, depression, and aerodigestive disorders such as chronic rhinosinusitis, gastroesophageal reflux disorder, GERD for short, asthma, and sleep apnea. And these conditions often occur together, so that people suffering from PTSD, for example, often have depression. Others have asthma, GERD, and/or PTSD. And having more than one condition has a greater impact on quality of life, functioning, perceived overall health, and unmet healthcare needs than one condition alone, and the impact grows with the number of conditions. Respiratory conditions have been prominent for responders, people caught in the dust cloud after the towers collapsed, and those who lived or worked in the vicinity of the disaster site. And up to 15 years after 9/11, 15% of enrollees had reported newly diagnosed asthma and continuing lower respiratory conditions, such as cough and shortness of breath. And 22% of adult enrollees reported a diagnosis of GERD, which is frequent heartburn or acid reflux over a period of months. When we examined the course of PTSD through 15 plus years, we found that most enrollees did not screen positive for PTSD. Others had PTSD that resolved, and some had later onset PTSD, and about 4 to 5% had persistent PTSD. And through our various survey waves, about 12 to 15% of enrollees screened positive for PTSD. And the occurrence or prevalence was higher among those caught in the dust cloud, people who were injured on 9/11, or who worked on the debris pile for more than 90 days, or people that lost friends and family members. Job loss due to 9/11 health-related conditions was an important factor in the persistence of PTSD. Additionally, survivors with PTSD had increased likelihood of tobacco, alcohol, and opioid use, and increased body weight. Their quality of life has been adversely affected, especially personal relationships, the ability to work, and having poor health in general. PTSD seems to ramp up the impact of other conditions, including, for example, the interplay between PTSD and lower respiratory symptoms. People who are exposed to 9/11 with chronic health conditions are more likely to retire early or lose their job because of health reasons, and PTSD is a big factor in this. Lastly, we found that PTSD predicts all-cause mortality, heart disease, and external causes of death, such as unintentional accidents and drug overdose. Independent of PTSD, 9/11 exposure is associated with increased smoking, alcohol, and substance use among adults, including misuse of prescription medications. We found that social support and social integration is important for understanding 9/11 health impacts, in that low support can exacerbate health impacts and high support can buffer them. On the positive side, our study of people injured on 9/11, we found about 30% of our enrollees reported experiencing positive psychological growth, also referred to as post-traumatic growth. And growth after trauma can take many forms, from recognition of new opportunities, making new or improved close relationships, having greater appreciation of life, and facing the future with more confidence. And with the new challenges from climate change and the pandemic, treatment for victims can consider post-traumatic growth and how personal growth may play a role in their future development. Turning to children, we found that they experience similar adverse health outcomes as adults, including elevated occurrence of asthma, behavioral problems, increased risk of substance use, and PTSD symptoms. And importantly, children who had a parent with 9/11 exposure and PTSD were more likely to have PTSD symptoms than other children. And regarding emerging conditions, we have found that 9/11 is associated with conditions such as heart disease, stroke, pulmonary fibrosis, and systemic autoimmune diseases, including rheumatoid arthritis and hearing loss. To date, we've also found a slight overall increase in cancer incidence among enrollees compared to the New York State population. Some specific cancers were elevated, including prostate and skin melanoma among responders and non-responders, thyroid cancer in responders, and breast cancer in non-responders. And we recognize that some of these elevations in specific cancers may be due in part to increased cancer screening. So we're going to continue monitoring cancer and also mortality, which overall has not been elevated among enrollees. And now a few words about lessons learned. Our experience shows the importance of establishing registries early on after a disaster and including both community members as well as responders, and that responding to enrollee health needs and concerns is a key to a successful registry. It helps enrollees get care, it shows that we care, and it shows how registries can participate in long-term disaster response by linking people to care. Yet many people with unmet healthcare needs are not enrolled in the World Trade Center Health Program. And barriers to care include just not being aware of the World Trade Center Health Program, or people not realizing that their symptoms may be related to 9/11, or thinking that others deserve care more because perhaps they might be sicker. And others worry about the stigma associated with having a mental health condition. We've been operating a treatment referral outreach program with staff trained in motivational interviewing techniques to help enrollees address these barriers to care and apply to the World Trade Center Health Program. Thousands of enrollees have responded to our personalized phone outreach and submitted their applications. And this includes Spanish and Chinese speakers and other groups underrepresented in the World Trade Center Health Program. Additionally, evaluations of disaster impacts should extend over time to include impacts beyond health, to include functioning, quality of life, and other consequences such as job loss. It's also important to understand impacts among the diverse subpopulations. For example, we found that volunteer responders with little or no disaster training or experience were more likely to have PTSD compared to professional responders. And understanding impacts of subsequent disasters is also important. And for this reason, we conducted a survey of our enrollees after Hurricane Sandy and found that it worsened 9/11 related symptoms and contributed to Sandy-related PTSD symptoms. And more recently, we conducted a COVID-19 survey to understand pandemic impacts, including impacts on the course of 9/11 related conditions. And lastly, it's important to minimize hazardous exposures during and after future disasters involving explosions, fires, and building collapses, including measures to protect responders and civilian survivors, such as shorter work shifts, providing adequate respiratory protective equipment, timely cleanup, and access to integrated monitoring and treatment for mental and physical health consequences, as the World Trade Center Health Program does. And lastly, lessons learned are also relevant to future natural disasters that, of course, are occurring more frequently these days. Thank you.
Thank you, Mark. That's really an impressive amount of work that's there. I really want to move right on to Barbara Rothman. Are you ready?
I forgot to unmute before I shared. You would think I haven't done this before. All right, can you see that all right? And I want to thank you for including me. I'm honored to be here today and be part of this panel. And as you've heard, one of the huge consequences of 9/11 has been PTSD. And this photo in some ways represents a lot. I specialize in PTSD and in the treatment of PTSD. And in this photo, that represents a lot of who we've treated since 9/11. So you're seeing a first responder, and obviously, as you've heard, a lot of PTSD and other problems in first responders. You're seeing the survivors, who you're not seeing in this photo, who's also affected. For one, the photographer, the journalist. And actually, the first people that I treated coming back from Iraq and Afghanistan were journalists, even before we were treating service members. And usually I tell people, you're probably not going to tell me something I haven't heard before. And the first people coming back from Iraq and Afghanistan, I was hearing things I hadn't heard before. It was horrific. And so you're also not seeing in this picture the service members who signed up and served after 9/11. So let's take a minute and talk about PTSD. It's the only anxiety disorder, and I still do consider it an anxiety disorder, that an external event is part of the diagnostic criteria, the trauma. And what's interesting is after 9/11, there was a lot of discussion in the field, in the PTSD field, because you see here witnessing the trauma. I think everybody around the world saw those planes hitting those towers over and over and over again. And there was a big discussion in the field. Could people witnessing it on TV, is that a criterion A event for PTSD? And actually it was decided that it wasn't, that when we came up with this criterion and talked about witnessing the trauma, it was more if you were, for example, on the scene of the crime, or if you witnessed the towers come down. The way I see PTSD is that people are haunted by something that happened to them in the past, and the haunting nature comes out in the re-experiencing symptoms. Unwanted memories, nightmares, flashbacks. People get upset when they're reminded in their bodies, and it really knocks them off track. There's a lot of avoidance and numbing with PTSD. In general, people with PTSD don't want to talk about it. They don't want to think about it. They don't want to do anything that reminds them of it. Negative alterations in cognition and mood. Think about this past weekend and all the different moods that you experienced. Folks with PTSD have a very constricted range. A lot of times the way I think of it is that they've kinked the hose. They are only feeling negative emotions generally, and they don't like that. And so they try to not feel anything, but what that does is it kinks the hose so they don't feel the good emotions as well. They can't feel the joy, the love. They know they love their family, but sometimes they just feel emotionally numb. A lot of arousal and reactivity symptoms in PTSD. Hypervigilance and exaggerated startle reaction. I think that a lot of times, even though we do see decreases in treatment in exaggerated startle response, I think you don't go through these types of events that lead to PTSD and walk through life quite as calmly as you did before. Now, what do we do in cognitive behavior therapy for PTSD? In general, we do what's called exposure therapy. And by exposure therapy, it's helping people to confront what they're scared of, but in a therapeutic manner so that it changes. A lot of our patients will say to me, Doc, what are you talking about? I think about it a million times a day. But it's like they think about it, the book opens and they slam it shut. So they aren't able to think about it differently. I actually love this quote from Mr. Rogers, Fred Rogers. Anything that is human is mentionable, and anything that is mentionable can be more manageable. When we can talk about our feelings, they become less overwhelming, less upsetting, and less scary. And that's exactly what we do in exposure therapy, in prolonged imaginal exposure. We think of an emotional processing theory. When something important happens to us, we need to emotionally process it. I make a lot of analogies to the grief process, and there's really no way to the other side of the pain except through it. And we think that for various reasons, folks that end up with PTSD avoid thinking about it. It's painful, it's scary, and they'll block it out. But what that does is it prohibits that emotional processing. And so then it just festers, and we think that's how it haunts them. So for adequate emotional processing, you want to bring up the memory, but you want to put it back differently. You want people to learn something in here and in here. And there are a number of ways to do it. So one is imaginal exposure, where we ask people to go back in their mind's eye to the time of the traumatic event and recount it out loud over and over and over. And we tape record them and ask them to listen to that tape every day. We'll also do what's called in vivo exposure, and that just means in real life, realistically safe situations that they've been avoiding because they feel threatening or because they remind them of the traumatic event. And they do that over and over. And you stay in the situation long enough to learn in here and in here, this situation does not pose the threat that it feels like. We do education, we do what we call emotional processing. So talking about the stuff that comes up in the exposure therapy, and talk a little bit about virtual reality exposure therapy. There are other evidence-based treatments for PTSD. One that's very widespread is CPT, cognitive processing therapy. And another one that's being used all around the world as well is EMDR, eye movement desensitization and reprocessing. So let's go to virtual reality exposure therapy. This is actually one of my favorite
takeoff momentarily.
Because the therapist can exactly control stimuli. If my patient's not ready for turbulence, I can guarantee my patient is ready for turbulence, I can guarantee it will be turbulent. And we can take off and land as many times as we need, all within my 5 therapy sessions and without leaving my office. And the research has shown it's very effective. This is also a little clip of the earlier virtual Iraq and Afghanistan. So what we do with the virtual reality exposure therapy and what we've been doing with service members and veterans is we do imaginal exposure to their most traumatic memories of serving in Iraq or Afghanistan, where they recount it out loud in the present tense repeatedly, and the therapist matches what they're describing in the virtual reality. And we can create almost anything that they describe from Iraq or Afghanistan. In one early study, we showed, in addition to decreasing their PTSD symptoms, that it decreased their physiological startle response to cues. And this makes me happy because I think one of the things that makes people with PTSD feel crazy is that exaggerated startle and hypervigilance. They can know in their minds they're not in a war zone, yet their bodies are feeling as if there's the same level of threat. So it makes me happy that their bodies are learning to become less reactive with treatment. There are 2 FDA-approved medications for PTSD in the United States, sertraline or Zoloft and paroxetine or Paxil. There's a lot of excitement about MDMA combined with psychotherapy. And I think things look like it's probably going to be the next FDA-approved medication for PTSD. We've learned a lot about PTSD after 9/11 and really from it. One of the only good things I think to come out of 9/11 is a wider recognition of PTSD. And we're trying to learn, and especially with this era of service members and veterans. The other thing is we realize that, as I mentioned, the trauma is part of the definition. So unlike other psychiatric disorders, the precipitant for adult PTSD is a known event, allowing for immediate intervention, presenting the potential to prevent the development of PTSD. In all of our stories we hear of PTSD, very often there's something that happens right after the trauma that could make it better or make it worse. And obviously we want to make it better. So we've been conducting a series of studies in a level 1 trauma center in the emergency room, and we start treating people in the emergency room. 3 months later, the folks that got the early intervention had half the rate of PTSD. So I think this is a very promising area. And obviously what we want to be able to do is do something in the field or in the theater. I'm going to take a moment and talk about the Emory Veterans Program, because this is specifically for post 9/11 veterans. We have 2 formats, one regular outpatient therapy, but the real innovation is an IOP, an intensive outpatient program, where we're able to bring in veterans from all around the United States, put them up in the hotel across the street from our clinic, and treat them every day for 2 weeks. We treat PTSD, TBI, MST, major depressive disorder. We have a TBI track and a SUD track for substance use dependence. We provide psychotherapy, pharmacotherapy, cog rehab for TBI, stress management skills. We have a sleep doc that works with us in the sleep lab. Everyone gets yoga, they get acupuncture for pain. We include the family members and help them navigate the VA system. In some ways, this is the best slide I've got to show you. In normal PTSD treatment, you can expect even up to a 50% dropout rate. PTSD is a disorder of avoidance, and that plays a role in treatment as well. With our IOP, we have a greater than 90% completion rate. I really think this is the way to treat PTSD. And they get a lot of therapy in those 2 weeks. Looking at 2,000 patients, they received 28,000 sessions, 33,000 hours of sessions, and it's effective therapy. This is the PCL, the PTSD checklist, a measure of PTSD. And you can see in the 2 weeks of the program, there are dramatic drops in their PTSD symptoms that are maintained up to a year later, and similar improvements in depression as well. We just published this study, and it's exactly what we thought would happen when you treat the PTSD, the suicidal thoughts decrease as well. Shameless plug for a book that's meant for the lay public, and it's got a lot of this information in it that we published last year. And if anybody wants to connect with us or find out more information or refer someone or refer yourself, please do. Thank you. David, I think you're muted.
Barbara, I was just going to say that was a very informative presentation. I'm sure that's going to stimulate a number of questions at the end. Very informative. So the next speaker, just to move right on, is Alboliz Santiago Colon. Ready? And I think you're on mute.
There.
Okay.
Thank you for inviting me here today. I'll be describing the World Trade Center Health Program briefly, then I'll move into our research and what we've learned there. And I'll touch on the implications for future disaster efforts and preparedness. So to start off, a brief history of the health program. It was established by the James Zadroga 9/11 Health and Compensation Act of 2010. It was signed into law in January of 2011, and it was launched on July of that same year. It replaced two earlier 9/11 related health programs. And on December 2015, it was reauthorized for 75 years, ending in 2090. The program is a limited federal health program that provides no-cost medical monitoring and treatment for certified World Trade Center related conditions to those directly affected by the 9/11 attacks in New York, the Pentagon, and in Shanksville, Pennsylvania. We serve two major groups: World Trade Center responders, who are people who were involved in the rescue, response, recovery, cleanup, and related support activities following the attack. It includes FDNY responders, World Trade Center general responders, and Pentagon and Shanksville responders. We also serve World Trade Center survivors. These are people who lived, worked, went to school, or attended child or adult daycare in the New York City disaster area, which I'll show in the next slide, from September 11, 2001 until July 31st, 2002. It also includes people who were eligible for certain Lower Manhattan grants. Part of our mandate is to fund research into the physical and mental health conditions related to 9/11 exposures. On the left, you can see the map of the New York disaster area. It is also used to determine World Trade Center survivor eligibility. On the right side, you can see the responder eligibility area. And these are available on our website as well. So on to research. Our mission is to investigate the health impacts and disability arising from the 9/11 attacks and to optimize World Trade Center responder and survivor care. Our funding is provided through grants and cooperative agreements, which are managed by the World Trade Center Health Program in collaboration with the NIOSH Office of Extramural Programs. So what have we learned? Last year, we published a review article of our World Trade Center related literature. It included all the publications, all the relevant scientific publications from 2001 up to June of last year. There were 944 eligible publications, of which 291 were funded under the program. The total literature, it's fairly balanced between World Trade Center responders, World Trade Center survivors, and World Trade Center Health Registry community members. There are several publications, including both responders and survivor communities. When looking just at World Trade Center, at program-funded publications, the majority is examining responders. The main areas examined overall are health burden and etiology. Other areas examined include exposure or intervention characterization. If we look at the distribution of World Trade Center publications in total, the majority of in percentage have been looking at adult mental health, which is expected, looking also at vulnerable populations and digestive disorders. When looking only at program-funded publications, the majority looks at aerodigestive disorders as well as mental health and emerging conditions. Aerodigestive disorders make up the largest clinical monitoring and treatment category. 56 of member conditions fall into this category, and there is growing evidence linking aerodigestive disorders and PTSD. Adult mental health represents 22% of certified conditions. Most of the research centers around PTSD. There are fewer studies looking at major depressive disorders. Studies suggest a relatively large and persistent exposure-dependent burden of 9/11 related PTSD. Cancer represents 13% of the program certified conditions. Overall, there's a moderate increased risk for cancer in the World Trade Center population. Strongest scientific evidence is for all cancers combined, and also thyroid and prostate cancer. There have been intermittent indications of excess cancer on bladder cancer, malignant melanoma, multiple myeloma, leukemia, and non-Hodgkin lymphoma. World Trade Center survivors exposed before being 18 years of age are the major study population within the vulnerable populations category. Approximately 5% of registry enrollees and 3% of program members fall into this category. Top certified conditions for this group are aerodigestive disorders, mental health conditions, and cancers. Ongoing World Trade Center related surveillance and research activities may periodically uncover new health conditions that need to be thoroughly evaluated. Currently, some topics of current interest include autoimmune diseases, cardiovascular diseases, and issues associated with cognitive impairment as the World Trade Center program members age. Our future directions include continue to identify effective approaches to improve the healthcare and well-being of at-risk populations. Identify knowledge gaps, especially in the area of causal determinants, disease progression, and emerging health conditions. Also, to identify prevention and mitigation strategies intended to reduce adverse health effects in populations affected by future disasters. So what does this mean for future disaster efforts and preparedness? Lessons learned from 9/11 have led and continue to lead many advances in medical and public health response by effectively communicating regarding the World Trade Center program and prompting new investment in disaster preparedness. Surveillance and clinical care of the 9/11 population, in addition to research on post-disaster health effects, have increased our understanding of physical and mental health risks associated with major disasters. In turn, this has helped inform the care management of people exposed to the 9/11 attacks, and it has the potential to inform the healthcare of other populations affected by future disasters. Here are some good resources if you want to learn more about our research. There was an MMWR published just today in our program. There's our research review. Additionally, if you want to learn more about the program itself, eligible groups, and other program characteristics, please visit our website. I want to thank all the program staff, all our partners with the Clinical Centers of Excellence, the National Provider Network, our data centers, the New York City Department of Health and Hygiene for providing quality care and research. Additionally, our science and technical advisory committee, steering committees, and other stakeholder groups for their thoughtful insight and advice on program improvement. And to all of those involved for their continued commitment to the responders and survivors of the September 11th attack. Thank you.
Alboliz, thank you so much, so much. One of the things I think will be a question later on for all the speakers, I'm giving you a little bit of a heads up here, is having been engaged in longitudinal follow-up overall number of times, you know, what were some of the challenges? What are some of the potential roadblocks? What are some of the things that facilitate that? Not to answer now, but just to think about as we're going along a little bit later. The next speaker that we have is Rachel Yehuda. And one of the things that I forgot to mention in the introduction is that she's also a director of a newly founded center at Mount Sinai for psychedelic assisted psychotherapy. Anyway, so Rachel, please. Looking forward.
Thank you very, very much, David. And thanks very much for including me in this very important event. One of the things that Mount Sinai got involved in very early on after 9/11 was monitoring environmental exposures at ground zero. And as part of this effort, a special program was established to monitor outcomes in pregnant women who had been at the World Trade Center when the towers collapsed. And of course, the initial concern was exposure of the mothers and their fetuses to toxins, but it quickly became clear that there would be mental health issues potentially, since many soon-to-be mothers were understandably emotionally distressed by what they experienced, and I was called to collaborate. And so we began to assess PTSD symptoms in mothers during their pregnancy and postpartum, and we were able to follow the mothers and their newborns for the completion of their pregnancies and for about 2 years following the birth of their infants. Now, what we learned was that as early as 7 months of life, the babies of mothers who had developed PTSD following 9/11 showed stress hormone levels that were consistent with those that were observed in their mothers with PTSD. And in fact, there was a very strong relationship between the maternal response to trauma and the newborn stress hormone levels. And furthermore, the infant stress response was highly influenced by the trimester during which the mother was exposed to the attacks. So by 2 years, the babies of mothers with PTSD had also shown signs of anxiety, like exaggerated fear of strangers and exaggerated response to novelty, compared with the babies of the mothers who had not developed PTSD. And these observations made it pretty clear that biologic and psychological symptoms in offspring of trauma survivors with PTSD might originate in utero, which was consistent with something we previously suspected based on our work with the adult children of Holocaust survivors who showed biologic changes similar to those of their mothers and also had more anxiety and PTSD themselves. But eventually, this led us to describe epigenetic effects in both offspring and trauma survivors with PTSD and answer many questions about how trauma effects are biologically inscribed such that they can be transmitted to the next generation. And of course, the public health implications of these observations are actually quite striking because they suggest the importance of prioritizing the mental health needs of pregnant women in the aftermath of a psychological trauma or disaster. Preventing PTSD in those women might also prevent a vulnerability in their offspring to the development of PTSD and other potential mental health problems. And again, this issue of identifying who is most vulnerable to mental health consequences following a disaster is really critical. Now, immediately after 9/11, many of us were concerned that the events of the day would result in a PTSD epidemic in New York City and maybe around the country, and tried to prepare for how we could address the mental health needs of an entire traumatized city or nation. And I was involved in many of these discussions about who should be treated, how early, with what interventions, and by which kind of providers. But what you heard from several people was that the big epidemic of PTSD that we were expecting never quite materialized in the way that we feared. And I think one of the problems that we faced during the first few weeks, days, weeks, maybe even months, was that we didn't know when the events that began on 9/11 would be over. And even a week later, we didn't know how many victims there were. And people feared more attacks, and there was an anthrax scare, and it just wasn't clear whether we needed solutions for helping people cope with ongoing stress or for helping them to prevent a PTSD from developing to a threat that they no longer faced. Now, in New York City, the acute trauma phase persisted for weeks, and it became very clear to me that responding to an ongoing stressor involves very different kinds of interventions than when you know for sure that an active threat is no longer present. So what you do in the immediate aftermath of an event for a population is also different from what you might do months or years later when someone is still struggling with symptoms associated with an event that is squarely in the past. And I think 9/11 really taught us this very, very clearly. The main thing that was needed following 9/11 were systems that could provide real information about what was happening and real services to people who were displaced or looking for loved ones or who were injured themselves or who were now at risk for physical illness. Systems were needed that could provide concrete assistance as people faced ongoing and major disruptions and losses in their lives. In some cases, people needed people to pray with or just be with. People needed to be both the recipients and the initiators of acts of kindness towards others. They needed to stand together, undivided by politics or anything else. They needed to be around people, their fellow survivors, who understood how to hold both relief and gratitude for being alive, that they survived this event with really deep sadness, grief, and horror for all that was lost. People wanted information on coping and resilience. They wanted to know what they were experiencing was normative and that they were coping and that they were resilient and that there were many heroes and that we would be all right in a while. You know, interestingly, what many mental health experts wanted at the time was to offer talk therapy, even brief cognitive behavioral therapy, to help people process their emotions and talk about the trauma, fearing that if they didn't do this, our citizens in close proximity to ground zero would be further at risk for developing PTSD. And I think one of the important lessons for the future is that in the acute aftermath of trauma, it is the messaging around coping and resilience that is going to be most effective for people. And while people are dealing with all the logistics of being injured or losing loved ones or being displaced or helping others who have been injured, endured loss, or have been displaced, this may not be the optimal time for processing traumatic memories. There may be time for that in the future. But then again, what about those percents that we know did get PTSD? What about the people that are at risk for not showing normal recovery? Maybe these people do need mental health assistance or intervention right away. But who are they? How do we identify them? And how do we find them in the aftermath of a disaster? While most people exposed to disaster and terrorism will indeed recover from their initial symptoms, as you heard, it may be important to focus on the ones we suspect may benefit from amplified services in order to prevent the development of PTSD or post-traumatic depression and anxiety. Now, we knew on 9/11, and we certainly know now, that those at greatest risk for developing mental health problems in response to a global disaster are those who display extreme reactions during and in the early aftermath of the trauma. And I'm talking about things like panic and dissociation and emotional numbing. We also need to be concerned about people who don't have available social support systems, including extended family, religious, or communities, as well as those who were and remain in close proximity to threat, loss, and horror. And often these are people with prior trauma and current mental health conditions, and these are the most vulnerable of all after a major traumatic event. For several weeks, after 9/11, most people were undergoing a normative response to threat. Those who were directly exposed or lost loved ones were dealing with logistics of rearranging their lives or planning and attending funerals. First responders were overburdened, had been converted to recovery operatives, and were also going to a lot of funerals. Many clinicians had the impulse to provide mental health trauma services for such folks and migrated to ground zero, often on their own, to do just that. But the ones needing mental health treatment in the early aftermath were those who already had mental health issues, which were exacerbated by the events. Hours and days after 9/11, Many of the doctors in my traumatic stress program at Mount Sinai and the VA had the idea of taking time off from work to go to ground zero to see if any of the first responders who were busy digging through the rubble, looking for survivors and victims, needed to process their traumas. However, our phones were ringing off the lines. People with PTSD from other traumas and combat veterans and many past first responders were highly triggered by the events of 9/11. And so I told my staff they needed to stay at work and take care of their own patients and the many persons who had successfully weathered prior traumas, who were newly presenting for treatment as a result of all they were seeing on TV. Since caring for these persons, to me, was the real mental health response that was needed. The physical and mental reactions to extraordinary challenge, they're designed to help us cope. We shouldn't mistake these reactions, which are essentially adaptive, with the events that have necessitated these responses, which are terrible. It is the persistence of stress reactions when the threat is no longer present that should become the target of mental health concern and services. Importantly, though, we can't wait, and we shouldn't wait for disasters to ensure that we have sufficient mental health capacity in our communities to support those who require our services in the event of a communal trauma. So the question is whether we've learned this lesson and whether we currently have these vital systems in place should the disasters strike again. Thank you.
Rachel, thank you so much. This opens up a period where we can have the audience ask questions, we can have conversation between the panelists, and if you do have questions, please put them in the Q&A and we'll sift through those and try to get as many as we can handled on this one. Now, Rachel, since you're up in front of us here, one of the questions that came out was, in the discussion of the vast impacts to people associated from in utero through direct survivors, first responders, I wonder what, if any, resulting changes to the treatment of PTSD has occurred.
I'm sorry, do you mean changes in treatments in PTSD in general?
Yes.
Yeah, so I think that Dr. Rothman pretty well covered the kind of treatments for PTSD that are available. Now, ironically, almost all of those treatments had been available before 9/11. And so have we actually come up with any new treatments for PTSD? And Barbara just touched upon MDMA-assisted psychotherapy, and we've just developed an entire center at Mount Sinai really to promote the study of psychedelic psychotherapy for trauma and PTSD. And I think that this has been really a major development and will hopefully be a very important player in helping people who are symptomatic. And I also think it's the kind of treatment that may be very interesting to people who are having trouble kind of calming down within months after a critical incident.
Very good, thank you. We have another question, and I think this was mentioned just briefly, but the person wanted to come back, and this is open to everybody here. I also wonder if there's been any work done on New Yorkers that struggled during and following 9/11 and now recurring trauma during the COVID pandemic. Thoughts?
Well, I can just mention and come back. I very briefly mentioned that one of the things that we find is important is to monitor the impacts of subsequent disasters, and in this case, disasters subsequent to 9/11. And the registry recently completed a COVID-19 survey because we wanted to learn about illness and illness severity and COVID-19 and pandemic experiences. and particularly we wanted to be able to understand them, but also since our mission is highly focused on 9/11 impacts, we wanted to be able to account for COVID impacts in terms of people responding to our most recent survey that we completed in January. So we want to be able to tease out better what is the course of the 9/11 conditions and what is due to a subsequent disaster. And as I mentioned earlier, what we learned from our Hurricane Sandy survey, it was a number of years ago now, is that people did re-experience 9/11 symptoms or had them exacerbated, and there were symptoms related to that disaster as well.
Yes, and it makes perfect sense because there's so many eerie similarities in terms of how a population is affected regarding the fear. So, actual numbers of COVID are high because there is a small percentage of a gigantic population that is getting ill, but everybody else is involved in the fear that they too might get ill. And again, very early in the pandemic about coming together, we're in it together, we're going to help each other. We're very reminiscent of what we saw in New York, and I believe also in Washington, right after 9/11. And these are the behaviors that will see us through to kind of we are all in it together and looking out for each other, I think will not bear well for a public health response. So I think that a lot of the lessons of 9/11 are applicable to this pandemic. And of course, every time that we have this kind of a threat, the people who we should really understand that are going to be experiencing the most difficulties are the ones that have already been under threat or that have already been challenged by mental health symptoms, because it's just going to be another trigger.
Another aspect, David, I wanted to mention was that, as we're going through this pandemic, we've heard from our enrollees that they feel particularly forgotten because the pandemic has just overwhelmed the news cycle, and it's important to reassure people that they certainly haven't been forgotten during all of this.
I know some of the stories coming out that because hospitals tend to fill up with patients who have COVID, that some other services tended to be delayed, and how that might have impacted individuals. Well, Mark, since I have you in front of me, there's a question here, which is, in the World Trade Center studies, was there no similarly observed control group? Such intense surveillance may have picked up many more diagnoses. Area digestive disorders may be more common in general population than expected, I guess, during this period. Thoughts on that?
Yeah, that's a very good point. And the registry actually does not have a non-exposed comparison population within the registry. It's actually very difficult to conceive of what that would be given so many anticipated health impacts. But we do have the ability to compare to general populations like New York State or New York City, and national data. And we also have the ability, the registry has people with a range of 9/11 exposures in terms of intensity. And so we do have the ability to look at 9/11 impacts across that range for dose response relationships as well.
David, can I interject on, I think, your previous question about COVID and 9/11?
Yes,
Because
please.
one of the things that we had to do with our veterans program with COVID was pivot and for a while make everything via telemedicine. And so that's, if you look for maybe a silver lining of COVID, I think it's been the widespread use and advancement of telemedicine. We've been comparing our results, and they seem just as robust with telemedicine as compared to in person. So I think that is one of the intersections.
And to add to that, Barbara, our program also expanded under telemedicine services to try to maintain the reach to our member population, and it had a really good response.
I also wanted to mention, related to this, is that since the World Trade Center Health Registry is nested within the New York City Department of Health, like many other programs in the health department, many of our staff were activated in COVID-related emergency response roles. So it impacted our staff's work and impacted, of course, our individual staff members in their own ways as we went through the epidemic. And one of the challenges for the registry is that we, found a way to maintain our core essential functions of communications and contact with our enrollees and responding to their health needs and concerns, and also continuing the core research mission as well.
All right. We have listeners from around the world, and I have a question for you from Nairobi. And I guess the question is, I'm wondering whether you have experiences in the treatment of PTSD programs in low and middle income countries like Nairobi, where events like 9/11 happen often and where there's little efforts on such treatments and even less focus on mental health generally. What can low middle income countries learn from these programs around 9/11 in the US?
I can start some of the discussion around that. What we call empirically based treatments, which are treatments that have been tested in research studies under controlled conditions. A number of them have been used in low and middle income countries, and also using local providers. For example, didn't Deborah Kaysen lead a study in, and I forgot where now, I'm sorry, I'm thinking in the Sudan, but I could be making that up. And they used the local priests and shamans and trained them to deliver the therapy. And so all of our empirically based treatments have been tested in different environments, including in theater, in a combat zone, which I think is really interesting. That a lot of times people feel like you have to wait for people to come back here or to be completely out of the danger's way. But when you think about PTSD, it affects one's functioning, one's assessment of threat and danger. And if we can treat the PTSD, even when someone is still under danger, I think it's going to help them respond better. There have also been, for example, we're developing an app now that will be kind of a light touch of exposure therapy, and we're about to test it. And if that works, we hope to disseminate it everywhere and to use technology in that way.
David, that's such a good question that came up. And one of the things that was talked about a lot after 9/11 was, whether services need to be provided by mental health workers. And I think the upshot of that is that there are so many different kind of people that can provide so many important services related to psychological first aid, and that this idea that you may have fewer resources in terms of psychology and psychiatry may be hampering for those that really have very more serious cases. But that in the aftermath of 9/11, a lot of healing took place in communities that was led by community leaders, chaplains, clergy, school principals, really good thinking CEOs. There were so many people that kind of understood how to kind of herd their people and develop and have the instincts of wellness, coping, and resilience that really had to do with kind of bringing people into the tent and looking out for them. I think all communities can do this. And I think that this needs to be the really important message of a tragedy. As much as 9/11 was the most horrible day in New York, I have to tell you that 9/12/2001 was one of my favorite days in New York. It made me feel like New York was this extended family, and that the world were our first cousins, and that everybody was part of the solution. And I think that it was a man-made event. There's no question. We can't, it's not a natural disaster. It was definitely malintent of people wanting to hurt other people, and that's really bad. But the idea of everyone coming together to kind of soften it, to console, to help, not all the help, as I mentioned in my talk, was exactly the right thing to do, exactly at the right moment, but the intention was certainly right. And so I think when it comes to healing communities, the key word is also community, of really coming together with whatever you've got and really try to make it work as a community. And I think that was really the most profound thing I learned after 9/11, that's what's going to save us.
I've learned to be a little quiet after each response to make sure others have an opportunity to pitch in.
David, yeah, I just wanted to add to Rachel's remarks that, in that gathering of communities, it certainly continues to this day. And as we speak, there are organizations like Voices of 9/11 are having 2 days of meetings and pulling people together. And, what we hear from the leadership there is just the act of bringing people together helps a lot. And doing that, more than once a year, but it certainly happens once a year. And that it's that act of gathering that's continuing to make a difference.
Mark, while I've got you here and you're being an environmental health person, the question that I have from one of the participants is anyone aware of what we have that's advanced the state of what proper respiratory equipment needs to be provided to those exposure to similar dust? Did I just put you on the spot?
No, it's a really good question, and talks about future preparedness. What I can add here is that there's actually not a lot of information in the literature that actually shows the benefits of PPE or respiratory protection, although it's a very important part of practice. And the registry had collected information on respiratory symptoms and conditions among first responders and cleanup workers. And people reported to us what type of respiratory protection they wore. It was nothing. Others reported wearing a cloth bandana that you see people wearing today sometimes. Others reported being issued a half mask respirator with a HEPA filter, for example. And others, like firefighters, had the air tanks with the full mask. And it wasn't a matter of wearing it all the time or some of the time. It just varied. Practices varied across people, but we were able to discern that particularly the half respirator with the filter provided protection against the risk of developing respiratory symptoms and conditions after 9/11. And that was an important piece of work, and it was recognized by the CDC. And that publication was in collaboration with CDC. And, I don't know if I have the latest. That might be something to look into, but, there is a need, as I understand it, to find a way to be able to wear a respirator and to have communication. So it's very hard to speak while you're wearing a respirator, and communications are essential. So I just can't speak to whether there is something like that that's actually available and in use or not, but it would certainly be something that would help.
And to add to that, I'm not aware of an exact paper article, but I can say that NIOSH, there are divisions in NIOSH that continue to do research on ventilation and proper PPE and all of that to advance our knowledge into having our responders or workers in general protected for several things. And we continue to learn from that.
Very good. Very good. I remember his conversations early on was that there's destruction, of the building. There many homes, that are in the plume going around. That how does one try to sort of disentangle that in terms of how one might think about materials that are used in buildings, in construction. Is there any story that comes out of this? I know it's very complicated, but anyway, if there are just some thoughts.
I'm sorry, Dave, I didn't hear the first part of the question.
Yeah, early on, when there was the collapse of the building, there are many materials that were all, coming at the same time, gypsum, maybe some asbestos, a whole number of things. And when doing a registry, there are other places where it's been done that it's a very discrete exposure, right? Chernobyl, as an example. But here it's very complex. Was there a way to try and disentangle, what might be the active ingredients? Is there some suggestion about materials in new construction that might come from this story? Tough question.
Well, what you're really asking is that do we have to now think about everything we build, also thinking about the possibility that it will be destroyed and we might have to cope with that. And I think that is really just an amazing thing that we now have to think about, because I do agree with you that it's not because, for example, there might be a natural disaster or an earthquake, but because there might be somebody who would like to destroy what has been built. And so, we could really think about the impact of living in a world where we have to do a lot of calculations about worst case, and planning for worst case and what the impact is on us for just, losing our innocence in this way. I'm sure that nobody who created this magnificent structure, the Twin Towers, was thinking about like, oh my goodness, what would happen if somebody actually destroyed this building? What would be the impact on our citizens? And, I like to think about the positive a lot, but I think that really this kind of reality does seep into our consciousness of the hazards, of are we protected, of how can we protect ourselves, and how many different aspects of our lives do we have to think about in terms of are we maximally protected? So it's a very provocative question in some ways.
Yeah, well, I think 9/11 has instigated some thinking about at least one aspect of this, David, which is evacuating from a modern high-rise building. And the registry, had hundreds of people who did successfully evacuate the Twin Towers. And there were external researchers, including some that David, who approached the registry, and we facilitated research that involved talking to those enrollees, and so there was some learning about not just structural factors, how stairwells should be designed and accessible, and the materials they're made out of, but also the behavioral and organizational aspects of evacuating from a building, and training. How should people be trained? How often? Who's going to lead people out? What are the organizational aspects to reduce panic in the stairwells and to instigate the evacuation? So that is something else to think about as well.
Yeah, Robin Gershon, well, she's my wife,
Yes.
did a study. And I think just to add to what you're saying as a take-home message is for units that are in a high-rise to be able to make sure that you have an identified leader, and that you also have the opportunity to rehearse for these. So it's more than a fire drill, but the idea is that people know what their role is and to be able to do that.
Yeah. Thank you, David. You did a much better job than I did on that. So thank you. We also did some work surveying some enrollees about their disaster preparedness in general, just the basics of having a disaster plan and having essential supplies and food and water and so forth. And based on what we found, there's definitely room for improvement, even among those who experienced 9/11.
Yeah, I was going to also bring that up. I think one of the things that happened after 9/11 was that certainly I realized that I never plan for disasters, and that my children don't plan for disasters, because we just walk around thinking, something happens, we'll just deal with it then. And this idea of really making sure that you have a bag packed in case you have to escape, or that you have water and food in your house in case you can't escape, or if you get separated from your loved ones, you have a common meeting place that you would all try to seek. These are such basic things that I think we still have not learned that lesson. And I don't know why, actually, because I think that it's such an important part of role playing. Maybe when we're raising our children, we don't want to scare them by bringing up the possibility that they might have to, they're anxious enough about school and about COVID and about, the basketball team or whatever. We don't want to say, oh, by the way, in case of a national tragedy or a disaster and we get separated and there's no communication, or an enemy invades our country, let's role play that. But I think that, here we are 20 years later, we have a global pandemic. We have many conflicts around the world. In many cases, many of us are leading good lives. But I don't think we've internalized a message of what it means to be prepared, either physically or emotionally. And I think that, one of the things that was so striking after 9/11 was this feeling of reinventing the wheel and reinventing it during a time of chaos when a lot of things were already known and should have been in place, but we were all so frazzled that we didn't think about what systems do we already have in place that might help us? What do we already know? It's hard to be calm when you're in a chaotic situation. But after the dust settles, in this case, literally, we have to say, okay, this happens in a month. What do we do differently? And I'm not sure that we have really gone through, the exercise. Yes, there's TSA screening. Yes, we take off our shoes at airports. Yes, we do a lot of things that, we didn't do. I'm not sure any of those things get revisited regularly to ensure that these are, in fact, the things that are keeping us safe. But I think that among the lessons we learned was that the time to plan for disaster is when you're not having one. And that mostly during a disaster, most of us will be okay. So for 95% of the people, we have to actually be doing something different than we might be doing for people that we really think are at greater risk. And there isn't a one size fits all. And that we really need to have this fantastic triage plan of knowing who's in what category so that we don't expend a lot of services doing things that we don't need to do and really target our interventions in a very focused way.
No, this is very good. As you were talking, I was thinking I lived in San Francisco, and everybody there in the trunk of their car, had a earthquake pack, right? And some of that was because there had been earthquakes, and there's a sense that it's going to come again. But so there's a little bit of a model, but how we might think about that, certainly in 1993, the first attack on the World Trade Center, for a number of companies, they had it so that they developed disaster packs that were strapped to their chairs, the back of their office chairs. So again, thinking about preparedness in that way is very important. Now, I'm going to get one more question in here, and how did systematic racism and classism work or affect the events of 9/11?
Wow.
Short answers only. No.
I can give you just one thought that just came to mind. Is I think in my mind it played a role in who was exposed in some way, because think about the rescue recovery workers, the firefighters, police, and so forth have less diversity in the ranks, and those responders tended to experience the greatest exposures. But then, there's something behind the composition, right, of the responders, so that can affect it. And it certainly, we spent a lot of time talking about access to care and treatments, and the structural racism, plays out in terms of who has access and who gets a diagnosis and who gets the treatment as well.
Yeah, one of the things when I was in the immediate aftermath of 9/11, looking at all the photos, that there were so many photos of just pictures, taking pictures of people kind of in disbelief, not being able to process what they were seeing. And when I looked at those pictures, I realized how diverse we are as a city. There wasn't a predominance of white or black. There was just a lot of everything, a lot of young and a lot of old, a lot of people from a lot of different classes, if you will. In the World Trade Center, you had Cantor Fitzgerald decimated. I mean, you had really everyone affected, and really this feeling of everyone in it together. Now, as the time passed, it probably was the case, as it always is, as it has been in 9/11, that those who are more disadvantaged will suffer more in the time of need. And it is something that, I hope that our systems work hard to correct. But I think because we were the target of terrorism against America, and all of us felt we were American.
Yeah.
And I really feel, for at least a brief moment, a brief blip, I didn't feel, I may not be the right person to understand if systemic racism and classism are happening, but I felt a tremendous kinship for everybody, and I felt everyone felt it for everybody else too. And it was, for a moment, a really nice vision, or probably it became what it eventually sometimes evolves into.
All right, Rachel, thank you. We've only got a minute here, and so before I turn it over to the Dean, I just want to have you all recognize and acknowledge that Dean Galea, very early on, and Rachel and I were talking before we all came on, what a social epidemiologist that very quickly saw how important it would be to be able to have data that could go to the health department to say what's the magnitude and scope and factors associated with this disaster. And so he's really become an expert in trauma epidemiology. And I think we owe a lot to him. And I hope I haven't embarrassed you too much by bringing that up, Sandro. But anyway, let me turn it over to you to kind of tie up this program.
Thank you, David. I was about to go back off camera. That was very nice. Really, I want to say thank you to Dr. Vlahov, but also Dr. Sfarfel, Santiago, Colon, Yehuda, and Rothman. I've learned a lot from everybody on this Zoom call. I don't know what this is. It's a Zoom gathering over the past 20 years, and today was no exception. I thought that you all have made seminal contributions really to our world's understanding around 9/11. I was going to interject with questions around sort of how what we've learned pertains to things like COVID, but I'm just going to leave that as a question hanging, because really I'm labeling it that way because to label for all our participants that the lessons learned around 9/11 have implications for other disasters, other mass traumas that we are all experiencing in very different ways and very different implications. But what the people on this panel have done throughout their careers is build a knowledge base that now informs how we deal with events going forward. And I think for that, we are all immensely grateful. Really grateful to you all for taking the time for this conversation. Grateful to Journal of Urban Health, which David is the editor-in-chief of, for co-sponsoring this. And thank you, everybody. On this somber day, I thought it was important to pause for a moment and to ask what have we learned so that we can always do better towards the end of improving population health. Everybody, thank you for